session. This is the most difficult thing because you laser or inject in PDR. Unless we have one study done, we are very sure that we are lasering all the PDR patients. So these are the classification. I'm not going in details. These are the studies which are done. So over a period of time, what many studies are done, and now what the protocol is by DRCR we are following for this thing for PDR to inject or laser. There are standard things, and treatment protocol what we are following is the laser or DME or injection or what we are doing it. Now the trial when it comes in the DRCR for protocol S, that study shows that effectiveness of the ranibizumab in the PDR patients. So if there is a 2 years follow-up of the ranibizumab injection patients are done, and the visions are there compared with the laser group, and the visions were unchanged. Only what the disadvantage of PRP was there, it was destructive procedure and adverse effect on the visual functions was not there. And many time in PDR patients with DME, we combine the anti-VEGF injections. So PRP has been the treatment for the PDR for over last 4 decades, and
how much was my timing? You're perfect on time. Perfect.
Yeah. So this is the study design. It was a randomized multi-center clinical trial was done at the 55 sites. All the participants were more than 18 years of age with type 1, type 2 diabetic. The participants have 2 study eye can be enrolled. PDR, no history of PRP was done. Best corrected visual acuity later score more than equal to 24. That is Snellen equivalent to 20 by 320. And eyes are with or without the DME. The primary objective was to compare the efficacy and safety of PRP with that of the intravitreal ranibizumab for PDR study. We did the first question is, does it not worsening or it is comparable with PRP, and is there any potential benefit of ranibizumab like vision throughout maintain or peripheral vision, macular edema taken care, or incidence of vitrectomy in that patients. Now PDR treatment schedule in the PRP group in 1 to 3 sitting, 8 weeks of randomization, all the lasers are done. Standard lasers with 1200 to 1600 burns or automated pattern lasers are done. In ranibizumab require eye with central DME vision loss at the baseline, and if the size and amount of NV increase during initial PRP, then additional PRP can be given. Now these are the chart which shows the change in the visual acuity under the curve analysis, where PRP group and the ranibizumab group has a quite good comparison for the best corrected visual acuity. And when there is a baseline DME, the ranibizumab group was doing the better compared to the PRP group. Now visual acuity with the baseline DME, if we compare both the charts, the significant difference, statistical significant difference we found in the ranibizumab group. Now more than 10 letter score improvements are there at the end of 2 years, where ranibizumab is more compared to the PRP patients. Now this is the eye developing center involving DME in the vision impairment, where both the things PRP group and ranibizumab, the visions are being maintained better in the ranibizumab group. Now in the complications of the PDR, in the study groups, in ranibizumab we have 6% RDs, 2% have neovascular glaucoma, where PRP group has 10% RDs and 3% of neovascular glaucomas. Iris neovascularization, vitreous emergent, vitrectomy rates, vitrectomy rates are much higher in the PRP group compared to ranibizumab group. The 2 years, if we see the regression of the NV, which is almost comparable in both the groups, and active NV also being controlled. So just for the discussion, DRCR net protocol S, where the PRP and ranibizumab is compared, the treatments is non-inferiority outcome of visual acuity not worse than PRP, and the summary is mean change in the visual acuity baseline in 2 years, it not worse, and superior mean if there is a curve analysis, there is associated diabetic macular edema. The superior mean visual field outcome and decrease occurrence of vitrectomies and decrease development of central involved DME. PRP rarely given for the failure or futility of ranibizumab patients. Now key aspect is in 2-year study, no obvious baseline difference between the group of complete and non-completers would suggest the bias. The clinicians were not masked in the study. There is a high adherence to the PDR treatment protocol, and primary outcome assessors were masked, and unknown if similar outcome in 0.3 biosimilar anti-VEGF agents are given. Typically able to complete it in 1 or 2 visits, that's the advantage of PRP. It's often long-lasting, require no additional treatment, no require multiple follow-up of the patients. For the completion, initial PRP, mean time for additional PRP is 7 months, and may cost us less than ranibizumab injection. And no risk of endophthalmitis due to the repeated ranibizumab injection for the 2 months, and no risk of systemic exposure to anti-VEGF. So in the conclusion, PRP is effective for PDR for last 4 decades and effective in 21st century as such. Ranibizumab is as good as, or at least say non-inferior to PRP for visual acuity at the 2 years of the age. It's effective treatment and substantial safety concerns are there, and longer follow-ups are required. In the patient with DME, it's doing very good. Only the cost factor is very high. So that's the end of my talk. Thank you.
Thank you. Thank you, Dharmesh. Personally, what would you recommend to a patient who comes to you?
As I say, for 4 decades we are treated for the PRP. So
Right.
cost is the factor, and multiple follow-up and repeated injection. So still PRP is remained.
Still has a
Sure.
Thank you.
Murthy
Yeah,
sir, if you'll negate the cost factor, then you will go for the PRP or the Lucentis?
I think we need the long-term outcomes from all of these studies. They are just short-term studies. We have had PRP, which we see at long-term. Probably in future, we would have a lot more data on how we can go about doing it, and whether we can stop injections completely after a period of time. If you're going to receive injections all the rest of the life, it's not possible.